Good afternoon, everyone, and welcome to today's webinar hosted by Region 10 chapters of HFMA. The discussion for today is around the Washington landscape. For today's presentation, I would like to welcome our guest presenter, Mr. Julius Hobson Jr. Julius is a senior policy advisor at Polsinelli, a Kansas City-based law firm with offices in over 20 cities. Mr. Hobson has more than 45 years experience in public policy, working both inside and outside of government. He primarily serves healthcare clients with particular emphasis on physicians, hospitals, home health, and long-term care providers. He also advises and lobbies on a number of other issues, including appropriations, budget, education, immigration, municipal affairs, tax policy, and congressional oversight and investigations. And I must admit, this is a very abbreviated resume from Mr. Hobson here. So without further delay, I will hand the call over to our guest presenter. Julius, please go ahead.
Thank you very much, Nikki, and good afternoon to everyone. I want to start with where it all starts. It's the Capitol, where Congress is. As Congress is the first branch because of Article 1 of the Constitution. In the House of Representatives, we currently have 238 Republicans, 193 Democrats, with 4 vacancies. Key group to watch because of the majority is the Freedom Caucus. This is the roughly 30 members of the House who are the most conservative, and they have great sway given the narrow margin of the Republican majority. We also like to keep track of how many health professionals are in the House, and you can see that number. The Speaker is Paul Ryan, Majority Leader Kevin McCarthy, Steve Scalise is the Majority Whip. On the Democratic side, Nancy Pelosi is Minority Leader, Steny Hoyer as Minority Whip, and James Clyburn is the Assistant Democratic Leader. The Senate started off, we're in the 115th Congress. They started off with 52 Republicans, 46 Democrats, and 2 independents. But because of the special election in Alabama, adding a Democrat, it's now 51 Republicans with 47 Democrats and the 2 independents caucusing with the Democrats. And we do have 3 positions in the Senate. This is, as you probably know, very important because it means a lot of the party line votes will look like 51 to 49, but the other part of this is due to the illness of Senator John McCain of Arizona. It does make for a dicey situation with regard to the minority, and the Vice President of the United States, by Constitution, from time to time will have to break a tie. In the leadership, Mitch McConnell is the Majority Leader. John Cornyn is the Majority Whip. For Democrats, Charles Schumer is the Minority Leader. This is his first term as leader as he succeeded Harry Reid of Nevada. Richard Durbin is Minority Whip. Patty Murray holds the position of Assistant Democratic Leader. That is a new position in the Senate Democratic Caucus. The legislative process in the Senate is fairly clear in the sense of most of what they're able to do is by unanimous consent. We have gone through what's called the nuclear option with regard to nominations. This first occurred under Democrats when they were in the majority, whereby they objected to a filibuster which called for appeal of the ruling of the chair, which resulted in you still have a filibuster for nominations, but it meant that for all executive branch and all judicial nominations except the Supreme Court, you only needed a majority of those present and voting instead of 60. That changed with after the 2016 elections, with Republicans holding the trifecta of House, Senate, and White House. Majority Leader McConnell pulled the nuclear option for the Supreme Court. So for all nominations now, it's majority of those present and voting. However, On legislation, the filibuster and the requirement for 60 votes still pertains. The majority leader, if he wants to break a filibuster or stop one before it starts, has to file a cloture petition which contains 16 signatures, and it ripens 48 hours plus 1 hour after the Senate convenes. President Trump has criticized McConnell and has asked on several occasions that they pull the nuclear trigger for a legislation. McConnell and many in the Senate, many Republicans in the Senate don't want to go down that road. They've been in the minority, so they understand what that means possibly in the future. The other thing that was, when the 115th Congress started a year ago, we all looked at these 10 senators. The Constitution requires that all members of the House of Representatives are elected to 2-year terms, and they're reelected every 2 years. In the Senate, 1/3 of the Senate is up every 2 years. In 2018, Democrats are defending 25 seats. Republicans are defending 9. These 10 Democrats who are up are in states that Donald Trump carried in the 2016 election. So we've all sort of focused on them to see how many of them would cross the aisle and vote with Republicans to sort of protect themselves, protect their flanks. For the most part, they have stuck together with the Democrats as a whole on legislation. One exception being immigration votes that occurred last week. Some of them have stepped over to vote for some of the president's nominees for various offices, but by and large, they stayed together. They stayed together on the attempts to change the Affordable Care Act, and they also stayed together on the tax bill. We may see a little more change as we get closer to the election, but they are the ones that we watch. The other thing that's important to understand, let me just hold on a second. To understand on the in the budget process in the Congress has to do with and one of the reasons they use this is reconciliation is a means by which Congress can deal with budget legislation and not have to worry about the need for 60 votes, and that's important. But what does also matter is what's known as the Byrd Rule, which was initially a rule, now it's a law. And the point is to prevent amendments or any language that is superfluous to the process. There are 6 elements of the Byrd Rule, but the one that counts the most is the one that says that any legislation that has a greater policy impact than a budgetary impact violates the Byrd Rule. The ruling comes from the Senate parliamentarian. If it violates the Byrd Rules, then there's a requirement for a 60 vote. It's subject to a point of order, and you have to move to waive the Budget Act, and that requires 60 votes. The budget process for 2018, therefore, had a budget resolution which contained the reconciliation instructions. The budget resolution must be passed by both houses in the exact same form. It is a concurrent resolution, but does not require the signature of the president, but it is binding on the Congress in terms of how it moves reconciliation. In this Congress last year, the reconciliation bill included instructions for a tax reform bill that would increase the debt by no more than $1.5 trillion. It included instructions to the tax writing committees to produce these bills. So this was the House Ways and Means Committee and the Senate Finance Committee. This resulted in enactment of the tax law, and some of you may recall it was called the Jobs Act, Tax Reform and Jobs Act. Well, ironically, the title to the law violated the Byrd Rule. So when Democrats objected, when they moved to waive the Budget Act, they didn't get 60 votes. So the title of the law was actually stricken. So everybody just calls it the tax law. It included changes in the individual brackets. and it repealed a good number of personal deductions. But it did lower the medical expense deduction from 10% of adjusted gross income to 7.5% for 2017 and 2018. Obviously, this will have some impact on health care. Another element is that, especially with regard to nonprofit health providers, is the idea of collecting donations from individuals. It made some changes in that regard, increases the limit on cash contributions to qualified organizations from 50% to 60% of taxable income. It also repealed the individual mandate fines. This is something else that's also related to the Byrd rule, in that you may have read some pieces in the press that said they repealed the individual mandate. Actually, repealing the individual mandate violated the Byrd rule. So what they did instead was left the authorization for the Byrd for the fines, but then repealed the fines themselves. So the requirement is still there, but the fines are no longer there. It is the Congressional Budget Office, which is an arm of the nonpartisan arm of the Congress, estimates that 13 million people will become uninsured under those circumstances. It also estimates that health insurance premiums will increase by 10% per year. In other areas of concern with regard to health care was with regard to private activity bonds. These were bonds that are quite often used by hospitals to go to the bond market and for expansion or maybe some other construction issues they may have. The House had a provision that would repeal the ability to do that. The Senate did not. The final text contained no change in current law, and that was good. But it did keep, both houses did keep a provision on the refunding bonds. So if you had bonds, if you got into the bond market to refinance, which is what that is, before December 31st of last year, you were able to do so. Can no longer do that. They cut the orphan drug credit from 50% to 25%. It's not clear. There was some objection to that from some folks who were afraid that might lessen the work on orphan drugs. That remains to be seen. In the nonprofit area, as you know, we have a number of hospitals that are academic medical institutions, and one of the things that they were attempting to do was to go after the endowments of large, well-funded private post-secondary education colleges and universities. So they set a limit to tax those endowments at the same rate as a corporate tax, and it was based upon a $500,000 endowment per student. The interesting thing about this was when they designed it, they were trying to hit the Harvards and Princetons and Dartmouths of the world, but actually caught up a school in Kentucky and a couple of others, like Berea, which is the school in Kentucky that actually use their endowments to help student aid. We'll have to see how some of the larger private institutions that have academic medical centers fare under these circumstances. Now, there are some consequences to this. The biggest one is implementation by the Internal Revenue Service. In the last several years, Congress has cut the IRS budget. They've lost 21,000 employees. So there's a question about whether or not they will be able to implement the tax law in a reasonable amount of time, since almost all the provisions became effective January the 1st. Normally, if you go under the Administrative Procedure Act, you have proposed rulemaking, which has to be published in the Federal Register. Then you have to have a comment period of 30 to 60 days. Department or agency has to take those comments into account and then publish final rules. And this could take well over half a year to do. So one of the questions is how will they proceed, especially since the president has mandated that he wants implementation so that people can feel the increase in their paychecks right away. But we also look at it from the standpoint of what does it mean for health care? How will this work out? They do have the ability to do emergency rules. They can issue guidances, as IRS did on individuals at the end of last year. You may recall the question about whether or not people could pay the 2018 property taxes if they were in a high property tax state in 2017. IRS issued a guidance and said only if you've been billed for it. It's not clear that that guidance was proper, so we have to wait and see. They can also use interpretive rules as well as the emergency rulemaking. And then what always happens anytime Congress passes a large piece of legislation, they make mistakes in drafting. So there's been the question about, will there be a technical corrections bill that could be enacted in this Congress? Right now, from my perspective, the answer to that is no. They use budget reconciliation process to get this done. A technical corrections bill outside of the budget reconciliation process will require 60 votes in the Senate, and they're not going to be there. So, and there's no intention of using the budget process this year, which I will come to shortly. So the likelihood of some kind of technical corrections bill making it to the president's desk this year is very slim. We also got a bipartisan budget act for 2018. As you know, we had a couple of government shutdowns, though very short. They finally reached agreement on how to fund the government, but that also contained a number of healthcare related provisions. The first CR extended the Children's Health Insurance Program, CHIP, for 6 years. The Congressional Budget Office had estimated that if you extended it for 10 years, there'd actually be budget savings. So the Bipartisan Budget Act of 2018 extends it an additional 4 years. So we now have a 10-year CHIP authorization, which is good. It extends the work of the Geographic Practice Cost Index floor 1.0% through December 31, 2019. One of the issues that comes up every year has been the Medicare therapy cap. That has been repealed. The Secretary has given some authority on how to do this on a regulatory basis in the future, but it's replacement with a limitation to ensure that people get the appropriate therapy. One of the problems in the therapy cap was, especially in physical therapy, was that patients were hitting the cap fairly quickly. It's an extension of increased inpatient hospital payment adjustment for certain low-volume hospitals, an extension of the Medicare dependent hospital program through September 30, 2022. We also got extension of the home health rural add-on, an expansion of access to home dialysis, providing ACOs the ability to expand use of telehealth and expand telehealth for individuals with stroke. This is obviously very important, especially with regard to expanding the ability to use telehealth because of the cost of, actually the reduction of cost in providing care. It also includes the provision to independently accredit dialysis facilities and to assure high quality surveys. There's a reform of the home health payment system that would begin in 2020 with regulations to be developed by the Secretary. There's also recognition of attending physician assistants as attending physicians to serve hospice patients, allow physician assistants and nurse practitioners and clinical nurse specialists to supervise cardiac and intensive care, cardiac and pulmonary rehabilitation programs. Both of these provisions sort of extend the ability to care for patients by providers other than MDs, but will certainly expand the access to care. There were some changes in the hospital dish allotments by eliminating the reductions that were scheduled for 2018 and 2019, and then maintain the reductions in 2020. So this is not the first time that these dish cuts have been postponed, and I suspect hospitals will be lobbying to postpone them again in the future. The physician fee schedule update for 2019 reduced from 0.50 to 0.25. That's helped to pay for the bill. Reduce outpatient therapy services payment furnished entirely or in part by a physical occupational therapy assistant to 85% of Medicare payment. This was a pay for. This was not something that this group advocated for, and they're not particularly happy about it. Medicare Home Health Agency reimbursement will increase by 1.5% in 2020, and SNF payment will increase to 2.4% in 2019. Which brings me to the White House. Normally in the process of doing things, Congress would act and the president would implement. But as we have over the last 25 years fallen into a much more partisan situation, then presidents have sought to do more under their authority on the executive side. This has led to the greater use of executive orders, which sort of picked up under the presidency of Bill Clinton, then again under George W. Bush, and then under Barack Obama, they sort of sped that up. During the presidential campaigns, each candidate says, I'm not going to do that, but when they get in office and they find they don't have as much power as they thought they did, they fall back to this. So this administration is no different. So executive orders have been used significantly by this administration to make changes in healthcare policy where they can, which also leads to people filing suits in federal court to try to stop that. Presidential memoranda don't get as much publicity as executive orders, but the memoranda are probably more important than executive orders because that's the piece of paper that goes to departments and agencies that tells them how to implement an executive order, and they tend to be longer and in greater detail. There's also the proposed rule and final rule process under the Administrative Procedures Act. The executive branch can use regulatory guidance notices. When a notice gets published in the Federal Register, it is effective on the date of publication, and a comment period is not required. Interpretive rules are another thing that's available in the executive branch. The executive branch or department or agency can say, we have interpreted the law and the regulations to do this, but we're reinterpreting that and saying we're going to do that, something slightly different. You also have presidential policy decisions and, of course, presidential nominations, which can also matter a great deal. On the regulatory side, we saw the outpatient rule for this calendar year reduce the 340B drug payments from average sale price plus 6% to average sale price minus 22.5%, which is a substantial reduction for hospitals. A number of hospitals, individual hospitals, along with America's Essential Hospitals and the American Hospital Association, went to court to try to overturn this rule. They failed at the U.S. District Court level and have filed notice for the appeals court, and briefs are due shortly on that. We'll have to see what happens. The Health and Human Services Department's regulatory provisions to promote program efficiency, transparency, and burden reduction, that draft rule is sitting in the OMB Office of Information and Regulatory Affairs for review. Last year, President Trump signed an executive order directing departments and agencies to review any rules and regulations that they deem to be burdensome that they can repeal. This is what HHS has submitted to OMB for review. It got there February the 1st, and that review period can go up to 60 days. We'll have to wait and see what happens when that comes out, because obviously we don't know what's in that and won't know until it gets published. In the Trump administration, I've listed the people who matter the most. I just talked about OMB. the regulatory review occurs in the Office of Information and Regulatory Affairs, which doesn't always get a lot of coverage. We now have a new Secretary of Health and Human Services, Alex Azar, and he is just beginning to form his staff. So it remains to be seen whether, what his staffing will look like. At the moment, it appears that the CMS administrator and the HRSA administrator will stay the same. Departments of Commerce, Labor, and Treasury also from time to time have impact on healthcare. For the Internal Revenue Service, he's just named someone to take that over. It may be a while before there's a confirmation there. And of course, Justice Department and Veterans Affairs. The President has submitted his fiscal year 2019 budget. He's looking for $69.5 billion of savings on the Medicare. Again, he would modify 340B payments to hospitals and require a minimum level of charity care. The 340B program has been the subject of oversight hearings in the House Energy and Commerce Oversight and Investigation Subcommittee. Had 2 hearings last year. Had another hearing last week about hospital acquisitions. One of the concerns from the majority party in the House is whether or not hospitals have been using profits from 340B payments to acquire oncology practices and then raise the price of oncology drugs. At the moment, there doesn't appear to be enough information to say that is actually the case. There was an article published in the New England Journal of Medicine a couple of weeks ago, but I personally have some questions about the methodology there. Would modify Medicare payments to hospitals for uncompensated care, reduce Medicare coverage of bad debt, pay all hospital-owned physician offices located off-campus at the physician office rate. Presidents going back several administrations have been trying to do this. Right now, under the law, hospitals that acquire physician offices that are off-campus that are more than 250 yards away from the main facility will be paid at the outpatient rate, not the inpatient rate. This seeks to do all of those at inpatient rates, and it would save Medicare money. Address excessive hospital payments by reducing payment when a patient is quickly discharged to hospice. There's allow ACOs to cover the cost of primary care visits to encourage use of the ACO providers. There's a desire to reform the physician self-referral law to better support and align the alternative payment models and to address overutilization. This is something that physicians have been trying to do for some time. The feeling has been that the self-referral law, or known as START, is too strict. It remains to be seen whether or not Congress would actually do that. Require prior authorization when physicians order certain services excessively to their peers. On this one, I have to tell you, I don't know how you would implement this. I don't know what the measuring stick will be. We would have to see how that would happen. Eliminate requirement of a face-to-face provider visit for durable medical equipment. Under Medicaid, $1.4 billion in savings. They provide a pathway to make permanent established Medicaid managed care waivers. Some of you may have seen that Mississippi got a 10-year agreement on its 1115 waivers. Other states may seek longer waivers. There's also a desire to speed up that process. Require documentation of satisfactory immigration status before receipt of Medicaid benefits. Let me back up a minute and say something about the Medicaid waivers. As you well know, the administration has started to encourage states to include a work requirement or volunteer service in their Medicaid waivers. States are starting to do that. Some states, as a part of that, are requiring Medicaid beneficiaries to reconfirm their authorization for Medicaid, the eligibility. Some every month, some every quarter. The thought there is that the number of Medicaid beneficiaries will probably reduce or drop over time simply because lower income people, aren't always able to keep up with paperwork. The other is, if they do have a job, can they get off from work to go to the local Medicaid office to do that, which, as you can probably imagine, is not something you can always do during your lunch hour. The other is a test allowing state Medicaid programs to negotiate prices directly with drug manufacturers and set formulary for coverage. Will be interesting to see how that goes in terms of implementation. Prohibit Medicaid payments to public providers in excessive costs, and reform GME payments under Medicaid. Some of these proposals, I must say, are somewhat vague, and again, we'll have to see how that would be implemented. Whenever I make presentations over the last year, I have included something I've not done in previous years, and that's a discussion of the Federal Reserve Board. And the reason for that is you have so many hospitals and physician practices that look to expand or make some changes to their physical structures, and that means they usually go out and borrow money. That's where the Fed comes in. We have a new chairman who just took over. There are vacancies for the vice chair, which the chairman was prior to becoming chair, and one other position. The Fed has said it will raise interest rates at least 3 times this year. We're looking at a possibility of a 4th raise. The last unemployment report and the last inflation report suggests that there may well be a 4th interest rate increase. If that happens, then healthcare providers who go out to borrow money will have to borrow that money at a higher cost. This will also affect the federal government and its borrowing, which brings me to the federal government's budget pressures. The tax law added 1.475 to the debt over a 10-year period. The Congressional Budget Office says that debt service is estimated to be $318 billion over 10 years, and that is before the Federal Reserve Board raised rates. We also had a continuing resolution to keep the government open that postponed 3 of the Affordable Care Act tax provisions: the medical device tax, the Cadillac tax, and the health insurance company annual fees. That added $31 billion to the debt. The Bipartisan Budget Act, which Congress passed after the last shutdown, added $300 billion. It is projected that the annual budget deficits will exceed $1 trillion for the foreseeable future. The Congressional Budget Office, by law and by rule, produces a budget and economic outlook report that comes out every January. They put out a notice that they would not be putting that out on time. They were waiting for the tax law and then the budget deal before they could produce that report to make sure that their numbers are accurate. I asked them this morning how soon they expected to get that, and they referred me back to their blog post from last month, which did not answer the question. So it could be another month before we see that report. The expectation is that they will also estimate $1 trillion deficit for this fiscal year, and as far as the eye can see, and probably a growth rate probably not to exceed 2% or a little bit more than that. That is also one of the reasons why I don't expect Congress to pursue a budget process this year. The Senate Majority Leader McConnell does not want Republican senators having to vote on a budget resolution that would include a $1 trillion debt. And so he's trying to push back on that. Speaker Ryan wanted to go through the budget process initially to do what he called Medicare, Medicaid, and welfare reform. He then dropped the Medicare and Medicaid and went to welfare reform, but McConnell has not changed his mind on that. He's still saying no. So we've got these outstanding healthcare issues. With regard to 340B, we're expecting at least the House Energy and Commerce Committee to produce a bill or more than one to make changes in the 340B program. One of the issues there, well, two of the issues there are transparency and reporting. Many of the hospitals don't specifically track their 340B numbers, but the majority party would also like to change the definition of patient and possibly the definition of hospital. Those definitional changes would certainly reduce the program, the size of the program, which is what Big Pharma would like to see. Meanwhile, Senate Finance Committee Chairman Orrin Hatch has sent letters out on this program raising questions. He specifically sent a letter to the HRSA administrator, and among the questions he asked was, does HRSA have the staff capability to oversee the program? Everybody knows the answer to that is no. But he also asked another question, and that question was, would the program have better oversight if it was transferred from HRSA to the Centers for Medicare and Medicaid Services? CMS clearly has the staff capacity to do that, but in terms of whether or not it would be program friendly, CMS would not be. We also have the issue of prescription drug costs. The new Secretary of HHS was asked repeatedly during the confirmation process about where he stood on reining in prescription drug costs. He comes from the drug industry, so Democrats asked him a lot of questions about that. It's not clear how or if anything will be done. As you well know, HHS does not have the authority to negotiate drug prices. Look for more on the impact with regard to state Medicaid waivers, the work and multiple registration requirements that I mentioned before, and other ideas that states may come up with. One of the things I do want to point out is that over 40% of Medicaid providers currently are employed. So when you back out children and the disabled, we'll see how many more would fall into the work or voluntary requirement. We also have the issue of the Affordable Care Act, cost-sharing reduction payments, and whether or not Congress moves to do something with that. The budget, Bipartisan Budget Act of 2018 raised the cap on discretionary spending for defense and non-defense. Now Congress has until, I believe it's March 23rd, to write detailed legislation on how to spend that money. Domestic spending was, the domestic cap for 2019 was raised by $67 billion. The president's budget proposes to cut back 58 of that. But we'll see. I expect Congress to appropriate up to the limit, but essentially they have to decide how they're going to spend that money line item by line item. And that would finish the 2018 budget, and then we'll be off to the 2019 budget. And the appropriations process for the fiscal year that begins October 1, 2018. If Congress stays true to form, it will not be able to pass its appropriations bills before that time. So we'll probably get a continuing resolution to keep the government going. And that continuing resolution would take us past the November elections. Earlier I said that certain things wouldn't happen in this calendar year with one exception. And that exception is if in the November elections Republicans lose either the House or the Senate, you could look for the Congress to come back in a lame duck session after the election and pass some of the things that they want to pass using the budget process while they can still do that with a majority of those present and voting in the Senate. That is a possibility. The other is our annual Medicare payment rules that come out starting in late spring and early summer. We will still be going through that process. As I mentioned earlier, the OPPS rule cut 340B payments. It's possible that they could go and do that again. At this point, I'll stop and turn it over to Nikki to take any questions that you might have.
Great. Wow, what a tangled web. Thank you, Julius, for this very valuable information. Before I take our first question, I would like to just remind everyone the questions panel is located to the right of your screen. Just type it in and we will take as many as time will allow. Your information was so informative. As soon as someone had a question, you came right back and answered it. So good job there. But yeah, if there are any others that come through, please send them our way. I will address one question about accessing the slides as well as a replay. In fact, so the slides you can get access right now. In that same floating panel, you'll see a section called handouts. Just expand that by pressing the arrow that's pointed to the right, so it points down, and you'll see a little PDF icon. The replay, Colorado does an amazing job of storing the replays on their website, so that is where you should be able to gain access certainly by this time next week. All right, so a couple other questions that came over may require you to pull out your crystal ball there, Julius, but one is asking, do you anticipate more or less stability over the next 12 to 18 months?
Actually, that's a good question. My first response is beats me, but after that, I expect more volatility, and there are a number of factors that would be involved in that. First is the elections process. The Democrats have been leading in the generic polling for Congress. Before I start on the elections, it requires me to do what I consider a disclosure, and I should have done an earlier disclosure, so I have two to make. One, whenever I make presentations on healthcare and ever mention the Affordable Care Act, some of you may be aware that under the ACA, a number of states operate their own state health exchanges. My wife chairs the District of Columbia Health Benefits Exchange Authority Board in the District of Columbia. Second, I am a native Washingtonian in the District of Columbia and a registered independent and as such in the closed primary system, which means I can't vote in any primaries, and that's because I think both parties suck. So having said that, now I can talk about the elections. The problem that the Democrats have is that their national leadership, both with Congress and with the DNC, has not put together their policies in terms of how they will appeal to voters. Polling has that they have been shown privately says that simply attacking Donald Trump as a bad guy won't work. But on the other hand, they've been able to win some of these special elections for state offices around the country. But that has been primarily because people at the grassroots level are pushing from the bottom up, and they're also raising money very, very well. You have 22 incumbents in the U.S. House of Representatives who are Republicans who have been outraised by their Democratic challengers. So as we get closer to these primaries, and our first one is March the 6th, you can see the volatility occur as members start to watch. And the first time an incumbent looks endangered, or maybe an incumbent loses in the primary, that tends to shake up things for the balance of the year. Democratic voters are more enthusiastic than Republicans. However, on the national level, the Republican National Committee has raised infinitely more money than the Democratic National Committee. But it remains to be seen when you have enthusiastic voters whether or not money can overcome that. On the Senate side, Democrats would need to win all of their seats that are up, all 25, which also means those 10 incumbent senators I pointed out earlier who are running in states that Trump won, plus win 2 more. And that would require a serious wave election. That does not appear to be on the horizon. But it's as I said, it's already governed one part of what's happening in the Hill, and that is the fact that Congress is not likely to go through the budget process in terms of a budget resolution and reconciliation prior to election day. So that will contribute. That's one part of the volatility, which is actually a little bit more predictable. The unpredictable part is the investigation by Special Counsel Robert Mueller. Anyone who tells you that they think they know where he's going and what he's doing is either lying or on something. He has proven with the indictments last Friday of the 13 Russians and the information that he filed today for an attorney who's the son-in-law of a Russian oligarch, that none of us know exactly what he's doing. So how he proceeds, any future indictments or guilty pleas will have an impact on the legislative process and will certainly have an impact on the White House. The third part of the volatility is the turnover rate in the Trump administration, which has been at a record high, both in terms of staffing in the White House as well as outside of the White House for various kinds of reasons, and it's possible there could be more of that. All of that takes away from the stability and can present a difficult problem with regard to accomplishing anything on the legislative side. Next question, Nikki. Hope that answers the question asked.
Awesome, thank you. Our next question is, do you have any suggested sites or specific resources we can subscribe to so we can always monitor this level of legislative healthcare specific details? Any suggestions there?
Yes, to our Congressional Budget Office, you can always sign up for email notices of any publications they put out, which is any kind of reports, papers, cost estimates for any legislation. They're very good at that. A second would be U.S. General Accountability Office. They produce reports on a daily basis on a wide range of areas. Those would be the two best governmental ones. But then I should say governmental nonpartisan. The other is go to departments and agencies, and on their websites, they all have places where you can sign up to receive email notices, anywhere from press releases to various kinds of data, and all, you know, and don't think of it just in terms of Health and Human Services. I signed up for notices for Small Business Administration, Environmental Protection Agency, Health and Human Services, Labor, because the Labor Department puts out regulations that will certainly impact management and healthcare facilities. Department of Education, as you well know, it's difficult to go through getting a medical education without getting student loans. So anything that occurs with regard to student aid is sort of important, especially with regard to academic medical institutions. Homeland Security, because anything on immigration, as you well know, physicians, residents who provide care when they get out of med school tend to show up in your high shortage areas such as rural and inner city. So anything that impacts the immigration process for them can be a problem, as it was last year when a number of residents did not have their visas approved in time for July report date. So think about departments and agencies, also Internal Revenue Service within the Treasury Department on any kind of circulars and notices that come out about taxes that would impact the nonprofit area, which is what most of your healthcare is. Or for that matter, for businesses, because you do have physician practices that are for profit, that are standalone. So think about it in those kinds of terms. The other is that there are newspapers all over the country that you can sign up for daily emails. Sometimes you can be down to specific about what you want to get. I like to do that to get news outside of the big papers like the LA Times or the New York Times, Wall Street Journal, or the Washington Post. Sometimes you get some really good stories about healthcare at the local level, which helps you understand how things may be impacted at the national level. Nikki?
Great guidance. Thank you so much for that. All right, looks like we have exhausted all of our questions. I'm going to share just very quickly some an upcoming webinar, but if you have a last minute question, go ahead and shoot it on in since we have about 9 minutes left. We have our next scheduled event on March the 20th, and I believe that title is Learning to Love CMS Edits. So that should be very, very interesting. HFMA's website, which is hfma-co.org, is where you can go and learn more information about this upcoming event. And yes, Julius, I think you have answered all of the questions. So at this time, it looks like we'll give back the gift of time. Thank you so much for sharing this great information. Julius Gobson Jr., ladies and gentlemen of Polsinelli, really in touch with things from the legislative side. So thank you for joining. Awesome. Thank you. And to everyone else, have a great afternoon, and we look forward to seeing you online in the near future.